Welcome to Clinical Conversations 102nd podcast. It comes to you from Journal Watch, your guide to the most important current clinical literature for almost 25 years. Go to the website at jwatch.org. I'm Joe Elia. It's September 24th, 2010. This week, we follow up with Professor Martin Dennis on the question of compression stockings after stroke. Then, we'll review the news of the week in brief. Here we go. The Annals of Internal Medicine this week published the results of the CLOTS-2 trial, in which some 3,100 patients immobilized after a stroke were randomized to one of two kinds of pressure stockings to prevent deep vein thrombosis, thigh length or below knee. The thigh length stockings won, but at a greater risk of causing skin breaks. About a year ago, we interviewed the principal author of this trial, Professor Martin Dennis of the University of Edinburgh, about the results of an earlier study in Lancet showing the superiority of no use of stockings over thigh-length stockings after stroke. He's kindly agreed to chat with us again. Welcome, Professor Dennis. It's nice to talk with you again.
Hello.
Let's review the work so far. The first study showed no benefit of thigh-length stockings over no stockings, and this one showed, and this one shows that below the knee stockings are inferior to thigh-length stockings. So, by analogy, can we conclude that the use of any compression stockings after stroke no longer makes sense?
Well, first of all, I'm sorry, but can I correct you in your introduction?
Oh, yes, you certainly.
Where you actually said that no stockings were superior to thigh-length stockings.
Oh, did I say that? And were they?
You did.
There was no difference. Is that right? They weren't superior.
That's right.
Okay.
There was no difference, so they were equivalent.
All right. I'm sorry for that. That's a very important point, and thank you for the correction. In that case, what have you established?
I think we've established over the two trials that, firstly, that long stockings don't have any useful benefit in stroke patients, and secondly, that given that short stockings are inferior to long stockings in stroke patients, they are very unlikely to have any benefit either. And the bottom line is that graduated compression stockings are of little value in stroke patients and should be abandoned as a method of prophylaxis in this group of patients. And indeed, guidelines from the British guidelines, NICE guidelines, have withdrawn their advice that such stockings should be used in stroke patients. That's
an advance, and congratulations for doing that work. That was a question that's been hanging for some time, hasn't it?
Yes, we started the trials because we saw a lot of variation in practice across the world. Some places using stockings sometimes, and some not. Some using long and some using short. And I think we've now, at least for the stroke patients, clarified that we shouldn't be using any. However, I think the results of CLOTS-2 are particularly interesting with respect to other groups of patients. Obviously, we can't say anything directly because we weren't testing stockings in patients undergoing surgery, for instance, which is probably the most common reason for being fitted with these stockings. But the fact that we found that long stockings were superior to short stockings probably suggests that we need to think about which length of stockings are being used for prophylaxis in surgical patients.
And is it the case that the shorter ones are being used now more often? Is that right?
As far as we can tell, yes. We looked at some data provided by the NHS in Scotland, and certainly 75% of the stockings purchased by the NHS in Scotland are short. So I think one can probably deduce that the majority of stockings being used are short. We also talked to Covidien, who provided the stockings for the trials, and they are obviously one of the major manufacturers of stockings, and they confirmed that worldwide there was a trend towards ever-increasing use of short stockings, presumably because they are relatively easy to fit compared with the longer ones, and they're cheaper, and maybe more easily accepted by patients. So this is a concern because when we then looked at the literature for our systematic review, we found that there wasn't a single randomized trial to show that short stockings reduce the risk of DVT. And putting that along the side of trials showing that long stockings are superior to short, it does really put the use of short stockings into question.
And speaking of deep vein thrombosis, then we're left with that problem and no good prophylaxis for it except a drug prophylaxis.
Yes, I think certainly in patients in whom anticoagulation with heparin or low molecular weight heparin is possible, that obviously provides effective prophylaxis. And I think in terms of compression, certainly we're now looking at use of intermittent pneumatic compression in stroke patients as an alternative to graduated compression.
And that's the focus of the CLOTS 3 trial, is it not?
Yes, the CLOTS 3 trial is comparing graduated compression, intermittent pneumatic compression with no compression in 2,000 patients immobilized after stroke. And we should be able to report those results in about 2013.
You've now studied about 5,000 patients with stroke. Have you been able to glean any other lessons from your observation, or is that data still unmined?
We have confirmed, as others have shown, that in general the deep vein thrombosis is more likely to affect a weak or paralyzed leg. We've also shown that probably 80% of the deep vein thromboses occur relatively early after admission with a stroke, probably in the first week or 10 days, and that it becomes less frequent as one goes through the recovery period. So DVT is predominantly a problem of the acute phase of stroke. We have looked at some preliminary data to see whether there are any markers of a particularly high risk of DVT in this group of patients. We wanted to identify whether there were factors which would identify immobile stroke patients at higher or lower risk of DVT. And this was surprisingly difficult. It may not be surprising that having a previous DVT or pulmonary embolus is a risk factor, but that only occurs in less than 5% of our patients, so it isn't very useful in the majority. And also those with increased limb weakness are at greater risk. But none of the other factors, such as smoking and obesity, were consistently associated with an increased risk of DVT. This has implications for us in trying to target our prophylaxis. It doesn't allow us to say this person's a particular risk, you should use more prophylaxis in them. In immobile stroke patients, we have to find prophylaxis which we can give them to them all.
So the work continues. I'll look forward to the CLOT 3 results, and I'll keep my eyes out for the other research that you do. And thanks for spending time with us, Professor Dennis.
Okay, well, thank you very much indeed. And I hope to talk to you again in about 3 years' time.
Okay, well, we'll set an appointment. Thank you. Here's a quick look at the week's most important medical news stories. The FDA has restricted use of rosiglitazone, marketed as Avandia, and the European Medicines Agency has recommended suspending sales of the diabetes drug. In the U.S., the intention is to restrict use to patients whose diabetes is uncontrolled by other treatments and who cannot tolerate pioglitazone. Next, it seems that mammography contributes only a modest reduction in breast cancer mortality. And that's not to underplay the importance of the procedure, but according to Norwegian research, the drop in breast cancer mortality over the past 15 years or so owes more to improved treatments than it does to mammography. Roughly 1/3 of the drop could be attributed to screening alone. Finally, in the top stories of the week, fingolimod has been approved by the FDA to slow progression of multiple sclerosis. The drug works by trapping lymphocytes within their lymph nodes, thus keeping them from infiltrating the central nervous system and doing damage. The downside of this, as you might imagine, is a higher risk of some viral diseases, such as influenza and herpes, among other things. Well, that's it for Conversation 102. I'll be back next week. The email address here is jelia@jwatch.org. Earlier podcasts are available at podcasts.jwatch.org. Clinical Conversations executive producer is Ador Yano. I'm Joe Elia. Join us next time, and thanks for listening.